Okay, good morning to all of you. I appreciate you having taken the time to come, and I hope you're as excited about listening to what I have to say as I have about saying it. The content of our discussion today has to do with the relationship between EMDR and HeadApp, and we'll explain that more in detail later. But EMDR was an approach that dealt with resolving traumatic issues, and in my practice, I thought that was enough to do the true therapy resolution. However, I realized later that my patients had another need that was not being met, and that had to do with cognitive difficulties and deficits. And so I found something like HeadApp that allowed me to be able to employ it and add it to my EMDR therapy. By doing that, I was able to see that the relationship between the two enhanced the therapy, so we did a more effective job and created a much more stable patient stability in terms of functioning, and it would be more long lasting. Yeah, the topics very briefly are as follows. The first one would be my talking about myself. At some point, you may want to know more about how I develop things. Also, what is eye movement desensitization and reprocessing? That's EMDR. What is computer-aided cognitive therapy and rehabilitation? The interrelationship between psychiatric disorders and cognitive deficits, combining EMDR and computer-aided cognitive therapy with HeadApp to maximize and consolidate treatment success. Also, using cases from my practice, I can explain to you the practical implications and effectiveness of that approach. We'll then come to the conclusion of all of what we discussed. And finally, we'll give you more information on the availability of HeadApp. Yes, I've been in the psychotherapy, mental health field for 56 years, and during that time I've had a great variety of patients, different ages from 5 to 90, and also with different kinds of backgrounds, of course. And in spite of the variety, there has also been a specificity in terms of addiction. I'm a licensed professional counselor in New Jersey and a licensed mental health counselor in New York City. I have a bachelor's and master's in psychology, and I completed the coursework for the PhD in psychology. I've served on the faculty of New York Medical College and New Jersey's medical school, UMDNJ, teaching psychiatrists. I published The Match, a highly technical book on addiction and psychology for psychologists and psychiatrists, and I hope to enlist them in terms of us adding something to the field. I presented at national and international conferences and on TV. I was the guest expert on Montel Williams' show for the Hollywood Child Actors and Drug Abuse segment after the death of actor River Phoenix. EMDR is a psychotherapy treatment that was originally designed by Dr. Francine Shapiro to alleviate the distress associated with traumatic memories. She developed this in about 1990. She had a model called adaptive information processing that posited that EMDR therapy facilitates the accessing and processing of traumatic memories and other adverse life experiences to bring these to an adaptive resolution. What that essentially means is that it reaches those traumatic memories and does some treatment of that so that it takes it out of the way of your daily experiencing in a harassing way. After successful treatment with EMDR therapy, affective or emotional distress is relieved, negative beliefs are reformulated, and physiological arousal is reduced. So in other words, by dealing with the affective or emotional aspect, we change the belief we had in that particular trauma, reformulate it, and we drop the physiological PTSD arousal that causes the harassment. During EMDR therapy, the client attends to emotionally disturbing material in brief sequential doses, while simultaneously focusing on an external stimulus. In fact, there is the next step is going to involve us with lateral eye movements. The lateral eye movements that I referred to are directed by the therapist, and the most commonly used external stimulus is that particular eye movement. To explain it more clearly, briefly, the therapist takes his or her hand and moves it laterally across the visual plane of the patient. And by doing that, it directs the patient's eyes and controls them. There are other stimuli, two more. One of them is tapping with the hands, although more briefly, they now have vibrators that vibrate the hands alternately. Everything is alternately or bilateral. There's also audio stimulation with a headset where the sound will be in the right ear, then the left ear, then the right ear, then the left ear. EMDR therapy facilitates the accessing of the traumatic memory network so that information processing is enhanced with new associations forged between the traumatic memory and more adaptive memories or information. And that technical phrase and paragraph is essentially saying it gets at things that are traumatic in a way that standard therapy cannot. It then allows that information and fear in the trauma to be enhanced and connected to new associations that are much less traumatic or non-traumatic. And so we have a more adaptive use of those traumatic memories than we did before. These new associations are thought to result in complete information processing, new learning, elimination of emotional distress, and development of cognitive insights. This too will be made much clearer in our future discussion, and we will be going into the number of steps that comprise the entire treatment of EMDR, and there are 8 of them. There are 8 phases to the treatment approach for EMDR. At the outset, I should mention, if you are seriously interested in becoming an EMDR therapist, you need to become certified. Number 2, these 8 phases are not an autocratic list that you must follow exactly. They teach us in certification that these are really just general outlines, and you roughly follow all 8 phases. First phase, obtain a client history as you would with any clinical situation. List the events that were and/or are problematic in causing trauma and triggering those events. Number 2, preparation. And there we encourage the patient to be mindful of the process, but at the same time not be afraid of the fear, which we will be resolving during that session. 3, assessment. This is where the patient begins to ascertain a specific memory and in a specific manner. So it becomes the what, when, where, negative beliefs they have about themselves because of the trauma. 4, desensitization. This involves the lateral side-to-side movements of the therapist's hand before the visual field of the patient. Sounds with a headset, for example, with alternating sounds. And there's on your slide, it indicates taps. That was the beginning of EMDR treatment. It is now done with vibrating pads, one in each hand. And while focusing on the traumatic event, they are experiencing these particular stimuli. It continues until the client's SUD score reduces to 0 from 10. During this time, new thoughts, sensations, images, and feelings may emerge. Phase 5 has to do with installation, and that is now that the treatment approach has dealt with the negative aspects and talked about positive aspects of that traumatic event, there is a connection from one to the other, is all installation really is. 6 is a body scan. That is, you and the patient checking for any physiological sensations that are left. For example, if you felt anxiety in your brain or you felt an increase in heart rate, we check now to see whether or not they are still there. 7 is closure, an attempt to deal with feelings and sensations left by using the process of guided imagery. This is one of those aspects that we determined during certification was not necessary or critical, but for those people that like to do things in their therapy outside of EMDR can do the same here by guiding the imagery connected with the new feelings that are no longer traumatic. The last and 8th phase is reevaluation, to be sure there are no issues related to the prior event's resolution. And this doesn't mean the feelings and sensations. This means, are there any other thoughts and feelings that are related to what we just resolved? It might be something that's close by, slightly different, and we would then continue to reevaluate that and to resolve the traumatic aspect. Regarding eye movement desensitization and reprocessing validity, people will say, how do I know I can trust this? What else is out there? And so there are other types as well as similar types of the eye movement desensitization and reprocessing therapy. Evidence from research. More than 30 positive controlled outcome studies have been done. So there's lots of data. Some of the studies show that 84% to 90% of single trauma victims no longer has PTSD after only 3 90-minute sessions. Another study funded by the HMO Kaiser Permanente found that 100% of the single trauma victims and 77% of multiple trauma victims no longer were diagnosed with PTSD after only 6 50-minute sessions. In another study, 77% of combat veterans were free of PTSD in 12 sessions. EMDR is today recognized as an effective form of treatment for trauma and other disturbing experiences by organizations such as the American Psychiatric Association, the World Health Organization, and the Department of Defense. I'd like to re-enter the discussion that I had at the beginning of the slideshow, and that was my assumption that EMDR, which I learned, was effective in resolving trauma for my patients, and that was all there was necessary to be. However, I realized afterward by looking at other aspects of their functioning that they had some deficits in terms of cognitive areas. So, HeadApp was something that I looked at and found would be the best solution to give us the other half of a complete therapy. Now, the HeadApp, I'll give you a brief understanding of how it works, and we'll go into greater detail later. The cognitive screening, training, and monitoring system aims to improve specific domains or global cognition by engaging users in cognitively demanding tasks. The tool assists the therapist in the treatment of cognitive disorders that affect specific aspects of attention, processing speed, perception, reaction and impulse control, working memory, planning and problem solving, language and everyday functions. And I think you'll agree this is quite a plethora of list of information. HeadApp provides both an in-clinic solution and a tele-rehabilitation solution for home patients. The web-based application can be used on any internet-enabled computer or tablet. We're going to discuss more details about the HeadApp cognitive therapy program. It consists of 7 screening tests and 2 questionnaires to detect which cognitive deficit the patient may have and which degree of severity can be found. Screenings are designed to assist the therapist in finding the most appropriate therapy modules. The system automatically recommends therapy modules most suitable to address the patient's specific cognitive deficits. There are 23 computerized therapy programs. This sophisticated, comprehensive therapy battery is available to help clients improve cognitive functions and compensatory skills. Okay. The interrelationship between psychiatric disorders and cognitive deficits is an important discussion to have. I'll reintroduce my statement that I thought that EMDR dealing with affective disorders was the most appropriate thing to do, not just first, but at all. And I did not realize till later that there were cognitive deficits that might not have been appropriate and obvious at the beginning of treatment, but were there and were left untreated unless we made an address of that after the use of EMDR. And so that brings me to my practice and choices that I made. I was right to look at the EMDR as the first dimension to deal with, because if a patient comes with something traumatic, you're not going to be wanting to talk about something that sounds more academic, like attention and concentration, because they're wondering how to get rid of the thing that's harassing them. So, while I was right to do EMDR first, I also kept that when I combined the therapy. So, I do EMDR first to clear the field, and then shortly after that, I will begin the HeadApp program. So here we have a comparison between the diagnostic disorders and those dimensions that are measured by HeadApp. And if you see the colors all across the bottom, they are the red, yellow, blue, and gray, and they fade off into lesser severity. So you can look across from, say, PTSD and see red to blue to yellow, et cetera, et cetera. It shows to what extent that particular cognitive skill of attention or memory is to PTSD and everything else. So the end result is cognitive impairment is an important factor contributing to poorer functional outcome in major psychiatric disorders, and that may be a new dimension for all of us to think about. Now we will discuss combining EMDR and computer-aided cognitive therapy, which in our case is HeadApp, to maximize and consolidate treatment success. So practically speaking, what I do before I start EMDR therapy and after I've gotten some kind of history as the first step, I perform a cognitive screening with HeadApp. In that way, it's sort of like a physician taking lab tests besides his clinical observation so that he has a view of the entire field and knows where he's going to go. Even though after I have done the screening, I will begin the treatment with EMDR therapy. At some point, I will know what I want to do with the therapeutic programs from HeadApp. Screening usually takes place in my practice. In this way, I ensure that my client goes through the screening exactly as specified and without distractions. The essence of this is to replicate the dimensions on which this was normed. So for example, if the average person or the typical person is taking an hour to do this, they need to do the same thing at one time when they're rested so that the results are comparable. The resulting scores show me the strengths and weaknesses in all core cognitive domains, so I know everything from the first few sessions. If there are deviations from the norm values, I carry out a specific cognitive training battery with HeadApp after successful completion of the EMDR therapy. In some cases, I initiate the training already between the therapy sessions. And you ask, between the therapy sessions, what does that mean? What that means is that HeadApp is self-administrable to the extent that it becomes a home program, so that after I'm beginning therapy sessions with EMDR, and at the same time, they are working at home doing something that we call the therapy plan for my supervised training of them. You can look at the therapy plan as the word homework. So I moderate what they're doing on their time, and it saves me my time so I can do other things in my practice. That is a very important time saver and makes things much more effective in them doing things without having another session with me. Okay, I'll be discussing cases from my practice, and I've chosen 3 of them that are very interesting. I think you'll agree. The first is a female 50 years old, white female, severely depressed and psychotic. And I must mention the proviso that I did not do any cognitive program to correct dysfunctions because I did not know an existence of them. So she presented with an issue that goes back to her age of 11, and her sister was 9, brother was 3. The father was a police lieutenant, and he decided that he was going to tell his kids about where he was going to put his gun. He had them in the kitchen. He put it on top of the refrigerator and used curse words and said, if you ever touch this gun, you're going to wish that you never did. And so doing that enraged her, mainly because of her 3-year-old brother who panicked and didn't really understand what was going on. So she came to the session, but this was a session probably after 2 to 3 years of therapy was the only time she mentioned this issue. The EMDR that was done with her had a picture of him putting the gun on top of the refrigerator, what he said to them, and where she felt it in her body. And so she was still enraged by this 40 years later. And I should also mention from a diagnostic point of view that it did not only seem like she was severely depressed and psychotic, but rather that there might have been a diagnosis, an alternate one, of dissociation, because she's almost stepped outside of herself. And instead of treating me the way she had for those few years, she almost put me in the place of her father and became enraged about things, and you were not sure whether she was seeing me in that way or not. However, we found over time, of course, by the diagnosis we thought and the medication that was used. I should mention also, she came from a hospital that diagnosed her as bipolar and gave her a bipolar medicine and the standard social work therapy. She got nowhere, and so we're here now with this EMDR. When she talked about the feelings of enraged that she had, she felt her feelings in her chest and stomach, and this SUD score, SUD is subjective unit of disturbance, and it's used a lot in cognitive areas of psychology. Her score was 10, the maximum. 0 is nothing, 10 is the worst thing possible. After the first cycle, she still had a 10 and was enraged. She noted the score of 10 with, it's still a 10. And I said, yes, okay, fine, whatever it is, we'll deal with it. Now, although her score was a 10 and she seemed quite adamant yet, after the next several trials, the score dropped to 5 or 6, but more notably, she indicated the content of her responses which showed an empathy and identification with the difficulties her parents had. And so she said, quote, my parents are good. They wouldn't do this to hurt us. Then she said, I really do understand. I have a teenage son and it can be difficult. Later yet in the trial, she was getting tired as the score dropped to 1. She then begged off doing another cycle because she felt so tired. The tiredness, it should be noted, after this almost 25 minutes of a session, the tiredness indicates that her brain was not interested in pursuing the anger anymore because it had been moved. It had been moved from short-term to long-term memory, and it's reflected in the content and the behavior of the patient. This is an important thing to pay attention to. So it's clear evidence for her that EMDR does resolve issues. However, there's a couple of cautionary notes. One of them is this was a 25-minute session, an amazing kind of thing in some ways, especially because it was so aggravating to her and so serious. But this is a rare event from the time point of view. Sessions for EMDR typically require more time. And not only that, there are issues very frequently that take at least a few sessions to be able to resolve in the way hers was. So that's a more realistic view of what happens when you do EMDR in sessions. There cannot be an expectation of quick response. And the other part is that even though we did not have the opportunity to use HeadApp because it was not available to me, I did not know of it, the next two cases will point out what happens when there is the combination of EMDR and HeadApp. Our next case is a bit more complicated, and we want to talk about this in terms of the patient. This patient at the time of presentation post-car accident was at age 44. It resulted in a coma, severe trauma, brain damage, and it should be noted, it gave him an additional opiate addiction period. To explain that further, I knew this patient before this, 14 years earlier, when he presented with an addiction problem then. We dealt with that and ended after several years, and then he recontacted me at the time of the accident. Because of the severity of the trauma from the accident, from his brain and his body, he was placed on multiple opiate-based medications, which helped only a little. And as I mentioned just recently, it also re-engaged his opiate addiction because he was already prone to go in that direction, only now he had to use them for a different reason. He had 2 to 3 physicians, surgeons, neurologists, and he attended physical therapy sessions. What I did from the beginning was to have to make a decision whether I could use HeadApp for some of the attentional and memory stuff, and instead of EMDR, or do I do it the reverse? I had to think about this a while because frankly, I didn't think EMDR had a role to play here at all, not at all. And so when I came to him and listened to him talk, he not only had problems with attention, he had severe problems with memory. He happened to receive a phone call at the time and talked to the person as though he really knew what was going on and said, okay, very good, so I'll have her contact you with the paperwork and we'll take care of it. He hung up. And I said, oh, so you're still working your practice with the insurance? He said, yes. He says, but my secretary is doing everything. And I said, so what are you going to do for this guy? He goes, I don't remember anything from the phone call. I said, oh my gosh, this guy doesn't really have much to work with here. So he had pain and he had an inattention. My decision was made to start with EMDR. Well, why would I use EMDR if we had an attention problem when I could just go to HeadApp? But the decision was made for this reason. The HeadApp would work with the academic part of attention. It would improve his attention. The problem with him, and what makes this still distinctive, is that the recall was affected not just by the brain's inability to do the academic attention and memory problems. It was also the fact that this was highly traumatized material and he would not recall it. So I saw the trauma related to the inattention as the first step. I also wanted to see whether I could do anything with his pain. So we tried the beeps for 15 minutes, and at the end I told him earlier, let me know whether it works or not. And so he finished, and I said, so how did it go? He said, well, it There's nothing. I said, it doesn't work at all? He says, no, there's no pain. And he also was able in the process to pay attention to his body and to the issue for 15 minutes. Now, how could he attend so long for that and not for a brief phone call? That led me to believe that I was probably right, but I was shocked that EMDR did anything for his pain. Absolutely. And so we had him go on the trail of pain reduction, which would help his pain medicine to have a better job of resolving the pain feeling. From there, I introduced the HeadApp, because here's the other aspect of this case. There were straightforward neurological problems, and there were dysfunctional areas of cognition, for sure. He was going to a cognitive therapist, but before you assume this was somebody else doing therapy besides me, she was. But she was only working around mathematical issues. And I'll go back to his history here. In college, he was such a math whiz that he sometimes substituted for his professor in teaching the course, and the professor felt that comfortable with him. So he was quick with math. Anyway, he was now at the point where he could not do simple problems. His 5-year-old son was better at math than he was. And so we decided that he's going to continue with this cognitive therapist as he had for a year, but he made no progress on 2 word problems that were in there. He could not resolve them, and it frustrated him. So we did HeadApp, and after a short period of time, a few weeks, he came back from a session with the cognitive therapist and was smiling, and he said, I did it. I not only solved both problems, but I showed her 2 different solutions for the 2 problems. So he was feeling better about himself, and that's why we continued with the EMDR and the HeadApp to improve both areas. But I first had to make the decision of which one to start with. Now, in retrospect, should I have said, and do I say, well, how do you know it wouldn't have worked the same or better with doing HeadApp first and then EMDR? This is one of those places where a clinician makes a decision based on experience, and you try it. All I know is that it worked, but I don't know whether or not the reverse would work. So I'm not ruling in or out either way. What was the most important issue to consider is that both worked for different reasons, no matter which one was started initially. This case is about a 26-year-old white male who had severe opioid addiction, severe ADHD, and severe family life and work issues that involve conflicts. Because this is a more involved case, we've chosen to present you with a quick overview of all the steps that I did, and then go back and explain in greater detail what each of those steps involved. So, step by step, the first is a clinical interview. One can never do anything with diagnosis or treatment unless you know something about that person's background and some tentative diagnostic issues. Control of the opioid addiction. That would have a great effect on us doing assessments if he were under the influence daily as he was. ADHD evaluation by the DSM-5 criteria that psychologists and psychiatrists daily use. HeadApp cognitive screening came next, with then recommendations for therapy based on that screening. And the last is that EMDR, which was not last in order, but EMDR was begun near the very beginning to reduce the effect of family life conflicts. Okay, what I did step by step is now a further discussion of each area. The clinical interview is the next. No diagnostic procedure or treatment approach can be done without a clinical interview, history, and so on. So that was done first. In that interview, I found that there were conflicts between this patient and both of his parents, particularly his father, his mother was much more agreeable to what he was doing and not as upset, but his father was extremely upset seeing him as the oldest child that would take over his business. So the father, having known me before, told him, look, if you don't straighten yourself out with his help, do not come home. So this was a traumatic reaction, of course, if one of us thought about being in that situation. And so we had our work cut out that would involve EMDR. And before we could even do that, the first order of business was to detox him and to go a step further, not just clear his brain of the opiate, but rather to then put him on a medicine that would block those receptors to avoid relapses. So we come to the second part of this, which is control of opioid addiction. I put him inpatient for 10 days. And during that time, his brain became clear of the opioid. And then we immediately put him on an injection of Vivitrol. I should explain a little here for those of you that may not be familiar. The naltrexone has been around since 1980 as a pill and as an injection, but it became more popular and became marketed as Vivitrol, Vivitrol. The injection, as opposed to the pill, is given to that person who cannot be trusted to take the pill daily and is injected every 3 to 4 weeks, and it occupies the receptor sites for opioid and alcohol receptors. And by doing that, it rules out the possibility of two things. One, no relapses, no urges. Number two, by controlling it to that extent, it allows us to do the clinical appraisal and treatment without that kind of conflict interfering with things. The next step would be the ADHD evaluation by DSM-5 criteria. This is a list of symptoms that essentially includes enough for ADD and ADHD diagnoses, in that it deals with inattention, hyperactivity, and impulsivity, all three aspects of ADHD and ADD in inattention. Besides that, I use a depression survey, and I often use a PTSD evaluation to help to rule out those mimics of ADHD, to be sure about the evaluation, more sure. After that, we began the HeadApp cognitive screening, and the screening results led to the following deficits: severe, focused, and sustained attention deficit, moderate to severe working memory deficit, severe reaction and impulse control deficit, moderate deficits in executive functions. Putting these together in just a brief reading, one can see that it's essentially a report about the likelihood of ADHD, and it seems to be clearly there. And among those, besides the specific ones in the first three, is executive functions, because he had great difficulty organizing and implementing his daily functions even without the effect of opiates. Okay, the next step was employing HeadApp's cognitive therapy based on screening result recommendations. And in that step, we want to mention that the HeadApp has 23 therapeutic modules. So from this large number of modules, the computer will choose not just any ones or some that might help, but those that are specifically customized for him. That's an important thing to remember, because this is going to be targeted in such a way that it'll produce the fastest results in the best way possible, and far superior to what clinicians can do, only what's in their head. The other part of this is that it's set up as a home training program, and there are a number of aspects to this. Number one, it's always available to him to go onto the internet and continue to practice those therapeutic modules that the computer has chosen. The clinician, the therapist, has some input in discussions with the patient as to whether something might be changed slightly here or there and tweaked, but mostly it's going to be following the plan from the software program. The therapist then makes homework session recommendations, when and so on, and how often. Then in the interim of all those results, we as therapists will discuss those with the patient so that he can see where he's been and where he's going. Beyond the HeadApp at this point, I am using also EMDR. EMDR is something that is begun early on and is used to the extent that it's necessary. The extent that was necessary here was to resolve and diminish those issues resulting at home and work. We discussed from the interview the conflict between he and his father, and the manner in which the trauma resulted when his father told him, if it doesn't work, don't come home. So we resolved a lot of those over many sessions and over months, but clearly the major emphasis on therapeutic success did not come solely from EMDR. In fact, slightly more of it came from HeadApp. And to explain that part, there was a point at about 1.5 years into the 3-year therapy that this patient said to me, Al, I think that I don't have ADHD anymore. And I listened to him and said, I observed the same thing. Why don't you discuss it with your psychiatrist? They did. He asked the psychiatrist to take him off medicine for a month, put him back on for a month, take him off for a month, and then the three of us will decide. And we all decided that he clearly, it's gone. And I'd like to put into perspective what that means. In 56 years in the field of psychology and therapy, I have never once seen or heard of someone who is able to fully resolve ADHD severe. Never. And yet this happened, and it did not happen in this case for EMDR, but it happened because of the HeadApp therapeutic modules. At that point, he was behaving differently in all of the dimensions we discussed earlier, and it was a major success. In conclusion, what we've learned from these cases, I believe, is the following kind of ideas. The cognitive impairment is an important factor in contributing to poorer functional outcome in major psychiatric disorders. As I said earlier, that's not the first thing you think of when you think of cognitive dysfunction and it being related to a psychiatric disorder. It just doesn't seem like they fit together. Impaired cognitive abilities are regularly found in several domains. That is, attention, working memory, learning, social cognition, and executive functions. And these are core aspects of one's functional cognitive abilities. And these are the ones that HeadApp deals with on a regular basis. EMDR therapy facilitates the accessing and processing of traumatic memories and other adverse life experiences to bring these to an adaptive resolution. And you saw from the EMDR treatment that we're exchanging negative experiences and replacing them with positive ones, and that equals the adaptive resolution. Computerized cognitive remediation with HeadApp has been shown to be effective in improving both cognition and functioning, and not just in clinical practice on a daily basis, which is a type of validation, but rather in controlled research, planning, and exercising of ideas. The elimination of emotional disorders, distress, and improving cognition leads to improved patient outcome in cases.